Great, wonderful. We are good to go. It is seldom that I am so pleased to be able to join anybody for lunch other than my own family. But this time I get to join all of you for lunch and someone who is like family in so many ways. I'm thrilled that I can share with you some time with Dr. Paul Farmer during this symposium on subtropical and tropical coastal resilience, where we're talking about social, economic, and physical adaptations, yes, and southward in the Caribbean, but also beyond in our world. The University of Miami Institute for Advanced Study of the Americas is thrilled to participate in this event. I want to congratulate Sonia and her team for all they've done today, and to say again how pleased we are to be able to host Dr. Farmer once more. His bio is available on the event website, and I don't want to take up really almost any of our time in that, except to tell you that he's one of my best friends and someone who I consider a mentor and a soulmate for many reasons. And the rest you can read online or hear about in many different ways. Want to get right into the conversation with you, Paul. And I have a first question, and then I want to read a little bit from one of the early pages in the prologue to your new book. But the first question, and this is something we think about a lot, you and I believe that humans cause the bulk of human suffering, probably also the bulk of our world suffering. And that means pandemics like COVID through to climate change. We also know that typically the humans who cause all that suffering are not necessarily the same humans that have to live through the majority or die through the majority of that suffering. So what are some of those key links between climate change and human suffering? And you say, and Partners in Health say, that injustice has a cure, and what's that cure? I know it's a huge question, but there isn't anyone I think better to help us to understand it than you.
Well, thank you. And by the way, Felicia, what better introduction than to be called a mentor and a soulmate, and to have it be reciprocal. So thank you for that. As a physician and an anthropologist focused on epidemic disease, but also focused on providing healthcare and strengthening healthcare systems, I think it's okay for us to have a position reading, as with feminism, right? When you have a position reading, you're trying to read things through a gender lens, and there are many other different ways of doing that. But I'm just saying, a lot of my take on this is really as a physician, and through the health angle, probably more the latter than the former. And so when I read about, or live through these dramatic events, hurricane, flood, earthquake, or political violence, I think you're right. I think that we see the impact of human agency on our world, which seems to be speeding up in ways that I'm sure are going to be well discussed in the course of this conference. But just as it's important to see the health impacts of these cataclysmic events, it's important to rethink the very notion of resilience with health systems in mind. And again, this is something you've worked on for a long time, as has President Frank and many others at the university. And so you asked kind of two questions. How do you make the link? And what are some of the things that might be done? And I would just use the same frame to say, one of the ways that we respond to crises like these, whether they're slow motion crises like rising coastal waters, or sudden events like a hurricane or an earthquake, strengthening health systems is a big part of it. They are emergency systems, they're care delivery systems, they're warning systems. And in a lot of places where we've worked, you've worked, I've worked, health systems are weak. if you look at COVID right now in the United States, you can see we have a weak health system. It's patchwork. I mean, really, we're going to have, in Massachusetts alone, for example, which is a smallish state of 6 million people or so, we have 351 local health departments. And we have God knows how many health school districts, right? So this patchwork system does not lend itself to a harmonized, as they say in public health circle, or a coherent response. And that slows down our work in strengthening health systems. So to get to that, my colleagues at Partners in Health, whether in Haiti, Rwanda, Malawi, Lesotho, Boston, Navajo, et cetera, we try to focus on some material things. And that may surprise some people, since I'm an anthropologist, and anthropologists are ever going on about culture and the social construction of things. But the material things that I think would help us a lot are staff, stuff, space, systems, and support. And the reason that it sounds like a slogan is because it is. How do you or it's also a mnemonic. How do you respond to a crisis? The being in the middle of one, as I'm sure you know, and as many of the listeners know, and the participants in the symposium know, being in a crisis like a hurricane or an earthquake or political violence is a very disorienting matter. I know that from Ebola, of course, but I also know that from the 2010 earthquake in Haiti, from various epidemics and the occasional pandemic that we've seen. And in the middle of that disorientation, it's hard to have a reasonable plan. There are many people who want to write them and publish them and send them out into the world. But the way that I get down to those, and I think many of my colleagues get down to these basics, is to think in terms of staff, space, systems, and support. So staff, like nurses, like community health workers, like physicians, like managers, like researchers who can focus on what's actually going wrong. Stuff, clean water, vaccines for COVID, whatever the supplies, antibiotics, first aid, etc. Space, are there health posts, are there clinics, are there hospitals that are available to those who are the most vulnerable? Because as you said, Felicia, some of the biggest architects of climate change and other disasters of the sort that we're facing now are not often the people who face the biggest risk. Systems, which are, as you've noted in the past, are often the weakest part of medical interventions. What's the system? In the middle of an Ebola epidemic, what's the system of infection control? Or more prosaically, what's the system of actually paying the nurses for the work that they do? And then support, which, sometimes we call accompaniment, but accompaniment really all those things. Support is critical. What families need in the middle of these crises are what they often need before them, and that's support. And again, it's important to underline the importance of psychosocial support, but even more so material support. Food, housing, freedom from fear of eviction or losing your job, freedom from fear of not having insurance. So I know that sounds very materialist, but those are some of the ways I try to think about crises of this sort, but also kind of to endure them and get through them, making a positive contribution.
I don't think it's materialist. I think it's about giving people dignity in how they're living through these crises. And it makes me go, before I go to the book, another question that I wanted to ask you, and have you talked to our group about. You have a very unique and particular focus on beautification and beautifying healthcare spaces that are often for the poor. I think there's a reason I'm asking these questions, but I wanted to get your answer, and then I'll tell you why I think that's so unique.
I'm laughing and smiling fondly, really, because one time President Frank came to visit me in Rwanda, and this was, I think, about 2005. And I had been we'd been friends, but this is rural Rwanda, and in a hospital that had been abandoned after the genocide against the Tutsi in 1994. And so we were reopening it, and rebuilding it and staffing it. There were no doctors in the entire district, about 250,000 people or so, but also no experienced seasoned nurses, managers, et cetera. So, and he showed up, and I was standing in, we were making what would be in Miami, a koi pond. We didn't have any koi in Rwanda, but we found other fish. And he said, Paul, what are you doing? I was literally down in the pond. So he was towering above me, as this is wont. And I said, well, I'm building a koi pond. And he said, oh, dignification. He said it in Spanish. We were speaking in Spanish. And, actually, it was from that moment on that I called it dignification, because as delightful as that exchange was, the question of dignification is, as you said, central to our work. How do we respect people's dignity? So I know that when I go to the Brigham and Women's Hospital in Boston, where I work, I expect it to be spotless. I expect it to be welcoming. I expect it to be even beautiful, at least parts of it. Certainly places where patients and their families might gather. And so we were trying to do the same thing in Rwanda, as we had in Haiti, as we have done elsewhere. And that is, how do you signal that you think the people who show up to this abandoned public hospital in rural Rwanda are just as important, or maybe more important, than the folks who might show up at a fancy teaching hospital in Boston? So I'm really committed to that. In fact, in the brief time between a class I was just teaching and this exchange, I was on the horn with some Rwandan colleagues, checking on some trees that we had planted there just a couple of years ago. And I know this reflects a personal obsession, but I think it's one that is welcome in the communities where we work, to respect their dignity by making things beautiful. Did I answer that right, Felicia?
You always answer this right, but that's so, what makes it unique are many things, but I highlight two. So you're taking the patient view and the family view, and you're also valuing people the same regardless of their level of income. Sometimes I walk into very poor places and everything is one color, brown and gray. Yeah. It's dark. And then you see a flower.
Yeah.
You see a plant. But the other is that patient view. And I can't resist saying this, because as a former cancer patient, I remember lying there and going into surgery and looking up and seeing trees, flowers, light on the ceiling. And somebody thought that people on a gurney would see the ceiling. Right? Yeah. And you realized that what we know as patients is that when you can look out a window or sit near a pond and see flowers, which is all about our environment and resilience, yeah, we feel better as well as dignified. And so I think it's you as anthropologist and you as physician and you as human being speaking. That's why I had to ask that question for this particular event. But I want, because I know that you have a very big book. I've seen this book working its way to reality for quite a while. And it's an amazing book, as all your books are. And this one is about Ebola and the ravages of history. And you suggested one page I might read from, and I now know why, and I picked a little bit of it. And so for those listening, what Dr. Farmer wrote, and this is in just the prologue: the precipitate extraction of wealth from earth and forest profoundly disrupted the region's ecology, and in ways that have contributed acutely to the Ebola crisis. Whether by panning or river dredging or excavations that rival the visuals of Mordor, mining spells ecological ruin. It has sparked the rapid, hazardous development of cities and towns where once tiny villages and small farms stood. But mining, urbanization, and deforestation occur across Africa and indeed the world. A couple of questions you asked, but I highlight the last one. Why should such a readily transmitted and lethal pathogen have confined its toll almost exclusively to 3 countries? among more than a dozen in close proximity. And so why those three?
Well, the three countries, as you know, are Guinea, Liberia, and Sierra Leone. And already to go from one of those small hamlets in the more forested regions into the capital cities was devastating and perhaps novel, although that's not clear, because in a medical desert, a clinical desert, it's also a public health desert. So there isn't a lot of surveillance going on about what's causing people to become ill or die. So we can't say with any confidence that Ebola had never hit those cities before, right? But I think in answering that question, which I struggled to do, by the way, in other words, I didn't know when I went to take care of Ebola patients that I didn't know anything about the history of Upper West Africa, as it's called. And so the question I was asking was a challenge to myself as I was trying to write that book. And, way up at the top of it is another anthropogenic change or event or series of them. And in this case, they led to war, civil war. And civil war spread across from Liberia to Sierra Leone and, affected Guinea as well. And so the areas that were most afflicted by Ebola were the areas that were most afflicted by war. They were also the areas afflicted by mining, by resource extraction, by deforestation. So even though a lot of ecological analysis is very ahistorical, doesn't have respect for the ravages of history, it still is a way of looking at a problem, a health problem, in a much broader context. I think that the best way of doing that is through social medicine, and you and I have worked together in social medicine for a long time. But I think the ecological perspective offers a lot. And of course, if you've lived in Haiti for a long time, as I have, you've seen the impact of coastal flooding, storms, and hurricanes for a long time. And it's related to the ecological disruption and deforestation of Haiti as well. The good thing is a lot of these problems, as big as they may seem, do have reasonable solutions, paths we can proceed. Again, a lot of what I did was to proceed with the staff space systems and support logic that I mentioned earlier, as mundane as it seems. But these big picture analyses, I think, will point to the same kind of precipitants as I did in this book. I remember that I wrote a little bit of that book in Mexico as your guest.
I remember holding these pages like they were, made of gold and trying to get a photocopy for you because I was so worried that there was no copy of what you had written. I remember that so well. This was this is when it was in Cuernavaca when you so kindly and generously were participating in our Lancet Commission on Palliative Care and Pain Relief. And when you made such an important point, we were, fighting for access to dignity at the end of life or at risk of death. And you said, but how did we ever get there in the first place? And we said, it isn't enough. Tell us, I have to tell them a little bit about that because that changed the whole commission.
Oh, well, thank you. Thank you so much. It was an interesting time to participate in a commission like that because it was also at the height of the Ebola epidemic or around that time. And so I did a lot of that reflection and work from West Africa, and you let me call in. But if you look back at, again, what are the precipitants of these problems, you can also apply that kind of logic to the question of palliative care with cancer. And I saw something shocking. I mean, you know about this, and we've discussed it many times, but just for those listening, I was astounded to hear in the late 90s and early aughts, after effective therapy for AIDS had been developed, which is a combination chemotherapy that suppresses HIV. We call it antiretroviral drugs, called them antiretroviral drugs. And, I heard people talking about palliative care for Africans with AIDS. And, which sounded great to me until I realized that what they were saying is, since they're African, they're not going to get antiretrovirals how can we ease their passing? I mean, that strikes me as an outrageous thing to say in a global political economy where resources from Africa, including diamonds, minerals, timber, and before that, slaves and gold, have poured out and continue to pour out. And we're saying, well, we can extract resources from Africa, but we can't possibly put in antiretroviral therapy. By the way, who helped break that logic? But George W. Bush, when he launched the president's emergency plan for AIDS relief, render unto Caesar. You know, that was and remains one of the greatest aid projects ever conceived in the United States. So this perversion of the term palliation and palliative care was, you know, just an outrage of inequality and a lack of imagination. And you know, I appreciate you saying that it was helpful for the commission, because it's not fun to say things like that, because the people making such commentary are very often your friends, one's friends and colleagues, you know. But this is why we need to keep going back, even in considering climate change and coastal resilience. We have to go back again and again to health equity, to equity in general, to social equity and health equity. And, you know, again, that's why I'm always perseverating about staff space systems and support, because this isn't, you know, this is the formula that everybody needs to flourish, not just us.
So, you know, sometimes, and this is, favorite Julio Frank comment now, we're victims of our own success. So what means success in public health and in global health for you, Paul? I've always wanted to ask you that question. And can we ever say that we're successful?
Well, you know, just because we often say that we aren't successful doesn't mean that we are never successful. For example, who would look at the uniquely poor performance of the United States in the COVID pandemic and say that we were successful? And but you can see success, what it might look like, even through failure and studying failure, right? So success in public health has so many traditional measures: infant mortality, juvenile mortality, life expectancy. I tend to look at the more critical ones like maternal mortality, because to alter or bring maternal mortality down where it should be, which is close to zero or zero, requires a whole lot more staff space and systems than, you know, for survival in the first year of life. Although those first 28 days or month, there's another set of issues we could discuss there, but I know we're not going into that kind of detail. So those are all conventional and well-accepted measures of public health success. But the ones I think that are more worthy of obsession, and I know a lot of folks are talking about this in this conference, are around equity and around systems, right? So when we look hard at health disparities, as people have been doing for centuries, right? I mean, in the 16th century, differential mortality on our continent or our hemisphere was so striking that none of the folks coming from Europe, for example, could fail to comment on it, right? And some of them were very disturbed by it, as you might imagine, right? So this is a centuries-long obsession, but do we have exactly the right metrics we need? And more importantly, how are we doing on the staff space systems and support? Because unless you believe that it is essential that there be these kind of health disparities, meaning they're somehow essential to our station and our species, you're going to be asking material questions about how to address them, right? And so I would, you know, when we went to West Africa to fight Ebola, one of the leaders at Partisan Health said, well, what metric should we use to evaluate our success? He said that. And I said, well, how about money out the door and the number of survivors hired? And I meant it, right? How much money can we put into these impoverished communities and in the form of staff space systems and support or money? And then how many people who have survived can we bring into our workforce? And of course, we're still there now. And a lot of our workforce, a lot of my colleagues are are former patients who survived Ebola. Now, I wish we had made sure that many, many more of them had survived, but I'm very grateful that we get to work with them now. Why isn't that a legitimate metric for public health success? How many people are working in public health? What kind of budgets are going into it? Who gets to be involved? How is representation of, you know, underrepresented in medicine, but absent from public health? So I think some of those tougher metrics are the ones we should use. They're equity metrics, and we should, you know, they might not be right on the first blush, but we should keep pushing it forward. Is there gender equity? Then what's our plan for that? Gender inequity, and then what's our plan for that? You know, in the university that we started in Rwanda recently, we just launched our first medical school classes, are now into the second year. And, you know, we had a target in mind of 70 to 80% young women in medical school, right? And we met that target. And it's, you know, it would be easy to keep on pushing forward the metrics of what we want our world to look like, right? We also have this terribly splintered public health system. It's underfunded. I'm talking about the United States again. It has been for decades, defunded, shelled, you know, rendered into an empty shell, you know. So how do we rebuild that? How do we make it more resilient? I never feel comfortable using the term resilient about humans, but I do about health systems, you know. And even then, resilience is a somewhat unambitious word, right? Because if it's a metaphor for materials science, it means the ability to spring back into its original shape. But who wants the US public health system to spring back into its original shape? Pre-COVID, for example. Nobody. You know, we want it to be better, stronger, tougher, more flexible. I feel like I'm preaching.
We need a little preaching sometimes. So if we're not using that word resilient for health systems, and I can't resist it, speaking about the US, you know, our world has changed a lot in a couple of months. We can, I think, hope for much more in global health. What should we be asking our new leaders in the United States to be able to make this health system, let's call it nimble, serve the people that make that health system possible, those who pay the taxes and live in this country. But also, what are we asking them to do in global health? And by the way, on climate and environment. So I can't resist asking that question because I think there's so much hope here.
I do too. I do too. And, you know, I would just say that some of the things that we're seeing now, it seems to me as an American, are quite reassuring, right? Because there is much more attention towards strengthening those health systems. As I said, public health has been starved in the United States for 50, 60 years. It's a tiny fraction of the amount of expenditures, public and private, on health in the United States, which are very high. But I know other countries where it's higher, and that it would include Rwanda, amazingly. So what I mean by that is the fraction of their public budgets, which are often derived from taxes, that goes into healthcare delivery, but including public health, is 20% of their public, you know, budgets. That's probably the highest on the continent of Africa. And they've also managed to do a pretty impressive juggling act, right? Where they're saying, yeah, we want there to be money for public health initiatives, preventive initiatives, upstream initiatives, right? But also for care delivery for the sick. Because, you know, as we all know, and you don't have to live through a hurricane, a flood, a drought, or an earthquake to know that when people are critically ill or injured, what they're asking for is not more investment in public health, but care, right? So the care system, the caregiving system, the caring system, that has to be resilient, and that has to be amply funded. And even in a very poor country like Rwanda, and I think they'd be okay with me mentioning that it's a poor country, they're putting a lot of their resources into building exactly that kind of system. And it's been a very remarkable thing to watch over the last 20 years. My wife, who is participating in this conference as well, has focused in Rwanda on building up community health endeavors and focusing on women and girls as part of that system, not just as recipients of services, but as agents who are actively doing the work, right? And, it's no surprise to us in any case that Rwanda is the country with the highest fraction of women parliamentarians in the world, putting those Scandinavians to shame, no doubt. And again, this is part of an effort to build really robust systems that are human-centered, humane, resilient, and effective. And I think we could learn a lot from Rwanda in the United States.
So we have a couple of questions, but I really want you and I to talk about that word caring. I've been thinking a lot about what it means to be a caring economy, a caring health system, and it does have something to do with gender as well and how we put that in. So hold that just for a sec, because we have a couple of, I think, interesting and important questions. So Christina Biala has asked, Dr. Farmer, I admire your work in Haiti. Do you see developing countries such as Haiti adopting universal healthcare as a resiliency measure? Or do you think there should be better collaboration between nonprofits and those governments in order to achieve that?
Well, first of all, the answer to the first question for me is yes, I do see Haiti doing that. And Rwanda has already done it. And a number of places where we work have adopted. Now, adopting a framework is not the same as having the staff, space, systems, and support to implement it. But yeah, I see Haiti going in that direction. And again, I'm sure Didier Bertrand will talk about this and others from Haiti who are speaking today. On the second part of the question, which you framed, Christina, as or, I would say those are not mutually exclusive activities. For example, Partners in Health is a non-governmental organization. In Haiti, it's called Zami la Santé. And by definition, of course, not part of the public sector response as a public sector. But you will notice, I hope, that that organization works pretty exclusively with the public sector. So for example, if we build a big tertiary care hospital in Haiti, after all of their teaching hospitals were destroyed on one day or so, we built it as a public hospital owned by the Ministry of Health, part of their response to try and build a tougher, more resilient healthcare delivery system. And so it has been in Rwanda, Malawi, Lesotho, Sierra Leone, Liberia, Russia, Navajo, Peru, Mexico, right? It's been trying to strengthen the public care delivery system. That's not always easy, but it's one way to be confident that your investments as an NGO, and University of Miami and Harvard are also NGOs by definition, it makes us more confident that we're building something that serves as a long-term investment in public health as a public good, right? And I think it's been an unusual path for NGOs to follow. It's the one I would recommend in healthcare delivery in any case. And it took a long time to grow that into a big organization running probably over 200 hospitals, and that's not counting clinics and health posts and the upstream engagement that is required in this work, meaning in communities. But it's the majority of those 20,000 employees in Partners in Health across the world, the majority are community health leaders, right? And they're working and living not far from the places they were born and raised. And I think that is a measure of, or a marker of resilience, when you have more people involved in healthcare engagement.
Well, and let me sort of add to what you were mentioning to say that, like, we're thrilled to have Dee and Jeff. This is a family affair, and that says something, because I want to thank Jeff for having done so much work, Jeff Farmer.
He's I'm sure.
He's doing a lot. He did a lot of work to make this possible. And so we're thrilled at the University of Miami, and specifically in my shop at the Institute for Advancement of the Americas, to have both members of your family participating with us, and in this conference as well. We have another question. It actually feeds, I think, very well on where you were heading with the first. That Christina said. So Eduardo Pesquera, who actually is part of the University of Miami's office for Mexico and Central America, and I've known him for a long time working for the Ministry of Health of Mexico, but he's asking a question that goes global. He says, Eduardo says, how can we influence large corporations that exploit natural resources, such as the rubber forests in Liberia, to take responsibility for the impact of their activities and the impact those activities have in global climate change and in population health? And of course, that's, I think it feeds well, because you're saying we want a public health system, but we also need people to pay for it.
Yeah. Well, it's a tough question. And Eduardo, if I had a simple answer, I would spout it here. But there are a number of ways that we should be pushing forward the health equity agenda with corporations. And let me just say that my experience after the earthquake in Haiti, and this will shock some of you, but I found the public health community, as it was self-described, not in Haiti so much as the international public health and international development community, to be much less easy to work with than with some of the corporations who we reached out to help us build this massive hospital. By the way, it meant building a hospital that was up to earthquake standards, way beyond those in California, solar powered so as not to increase the trashing of the environment. It was probably the largest it probably is still the largest solar powered hospital in Latin America and the Hemisphere, Caribbean. So with those aspirations in mind, we went to corporations and said, hey, how can you help? Give us stuff, right? This is, and we've done that again and again over the years, right? But that's just asking them to help. Corporations also need to pull their weight in terms of taxes and their own investments in the health and well-being of the communities in which they work. Sometimes those communities are vast and global. I doubt there are that many big corporations, and this would probably be true of Firestone in Liberia as well, Firestone, which is later bought by a Japanese company. But I would be hard pressed to point to a number of corporations who really should be self-satisfied with the amount of work they've done to promote global health equity. And I'm sure there are one or two out there out of the millions, but we all have to invest more heavily in building this kind of fetishized resilience we keep talking about. And I think corporations can do a lot more. I would certainly invite them to support our work. And this is after having said that probably the largest donors, including of in-kind contributions for that big hospital in Haiti, a lot of them were private companies, and maybe some of them donated the IT backbone that would link the radiology services and other services to places where there are lots of radiologists to read CAT scans or X-rays. Some of them helped us with the solar, some of them helped us with everything from building a factory that used only local peanuts to make ready-to-use therapeutic food. That was Abbott, and we didn't ask them for drugs or as a pharmaceutical company, Abbott and AbbVie. We were asking them to give us technical assistance to build this factory and also to staff it and teach us how to do it. And they did. And that's a 10-year collaboration already. So I think, and let me put it more cheesily, we should guilt trip them. We should plead with them. We should beg them. And we should also say, hey, this is part of your duty of living in this troubled but beautiful planet, living on this troubled but beautiful planet. They're varied and complementary ways of, reminding people that if you make a zillion gazillion dollars, and we've seen this happen during COVID, then you have obligations too, right? And those obligations are to your community. And the most extravagant way of imagining our community is the community of the world.
Last and the closing thoughts.
Already?
I know, but I've been, cooking up this idea that I also called an economics of hope.
Nice.
But it has a lot to do with what you were saying about studying. And I think going back to the idea of caring, we see a lot of suffering. We see a lot of suffering of our planet and destruction. How do we help the people who work on this to be able to continue to care and to have a space in that economics of hope? How do you keep them going? How have you been able to do that?
Well, the first thought I had is probably personal psychopathology. I need hope to keep going. All of us do, though, as a species. And when words of encouragement or prayers or reassurances that we're of presence or attentive listening, when those fail, as they sometimes do, but not often, don't forget the material constraints of hope, because that's the first thing we forget is to hope. Maybe you need staff, stuff, space, systems, and support. To have hope, maybe you need to have a job. Maybe you need insurance. These are these material matters that really undergird a lot of hope. Just to be self-critical, I remember in my first decade in Haiti, when I was still in between, I was in medical school and residency and infectious disease training. I heard again and again people, maybe young people, but also patients who were the parents of young students. They would say, well, how can you help my daughter go to medical school or be how can you help me become an academic? And here we are in rural central Haiti, no electricity, no running water. When we got there, no health professionals of any sort. And I kept on saying, well, this is not why we're here. We're here to deal with a crisis in healthcare delivery right now. And I should have done it. That's not reverent listening. If they were asking to be, health professionals, parliamentarians, researchers, CEOs of a company, why wasn't was the right answer not? Those are legitimate aspirations. Those are the ones I had and my classmates at Duke or Harvard or lots of other places. We had those same aspirations. Why should we impoverish other people's aspirations? And so that's just something that I think I missed, and it gives me hope now to focus more on exactly those problems. That's why we started that university in Rwanda, to actually respect other people's aspirations and hopes. And it's given us more hope too.
So we end on this message of hope, where other people's hope builds on itself, right? And builds on ours. And so that means that we have a kind of energy that will hopefully generate change in our world and make, as you said, this beautiful planet a somewhat better place going forward. Paul, thank you as always. I know that the audience and all of those listening enjoyed this tremendously. I want to thank again Jeff for making this possible and Sonia for the event, and say that we want to have you with us again as soon as possible. It's easier now by Zoom, so we're going to keep asking for your time if you are able to keep giving it. Thank you for all you do.
Able and willing, my dear, very much. So thank you, and good rest of the conference to all those listening. And thank you for the contributions from across the Caribbean, Latin America, in the United States, to these presentations, which is very impressive. Thank you.